See you here today, an exciting day to have Dr. Anthony Fauci here to provide his wisdom and knowledge and to tell us, give his perspective on a career that I don't need to go into detail about. I will for just a few minutes, but it's unbelievable. And one thing that I am so appreciative and admire about Dr. Fauci is that he is the ultimate public servant / scientist, as comfortable at the bench as he is in the Oval Office. And Dr. Fauci, your legacy is incredible in terms of how you've translated basic science, clinical science to transform public policy, obviously for HIV, for COVID, and for so many other infectious diseases. So we are here today at UCSF Pride Hall, our brand new state-of-the-art building for San Francisco, where groundbreaking research is being conducted in critical areas of public health, infectious diseases, and other chronic diseases, diabetes, and other public health issues such as trauma. And Dr. Fauci, just for your knowledge, here at Zuckerberg San Francisco General, which is an anchor of our public health system, the only level 1 trauma center in San Francisco, as part of the public health department and in close partnership with UCSF, this institution receives over $100 million of NIH funding. And so a lot of the people here are recipients of grants from your former institution. I'd also like to thank and acknowledge Dr. Susan Ehrlich, CEO of Zuckerberg San Francisco Hospital, for helping us coordinate and arrange today's event and making Zuckerberg with her team what it is today. Dr. Fauci is a dedicated public servant, humanitarian, global health leader who saw us through the most challenging public health emergencies of our time. And today he continues to share his expertise to help the next generation of public health leaders to tackle the challenges to come. And he is incredibly generous with his knowledge and his time and his wisdom. I can think of no greater champion for public health preparedness. And with that, I would like to turn it over to Dr. Fauci because he has a lot of knowledge to share with us today. And we'll also, I want to make sure there's plenty of time for the questions that you may have. Dr. Fauci, thank you.
So my slides are up now. Thank you. Thank you. Thank you so much. It's really a great pleasure to be here with you this afternoon. I have a very warm spot in my heart for the city of San Francisco and a lot of friends that I have had for a very long period of time. Just looking at that picture, see, that was me before COVID. So look at me now. Anyway, I'm going to talk to you as I had mentioned when I spoke to Grant. Grant, thank you so much, and Susan for your. Is it working? Oh, here it is. Good. For your hospitality and inviting me. I'm really very, very pleased to be here with you. I'm going to talk about pandemic preparedness and response, and the main component of my discussion is going to be lessons learned from COVID. And I'm going to give just a bit of a background before. I know most of the people in the San Francisco Bay Area are very well aware of some of the fundamentals that are the underlying basis of the lessons I'm going to talk about, but I just want to give a quick overview first. But before I do, I want to take this opportunity, I mean this sincerely, to express my condolences to the people of the city of San Francisco for the loss of an icon, not only in this city, but in the United States and the world, Dianne Feinstein, who I had the real privilege of knowing during the early 80s when she was mayor of San Francisco. And she was leading the response for persons with HIV in the city when others were backing away from it. And I believe that the courageous physicians and nurses and healthcare providers, many of whom were then and are still now very close personal friends of mine, really were the prototype of phenomenal care for persons with HIV before any of us even knew it was HIV in 1981, 82, and 83. So I want to take this opportunity to just pay my respects. And it was one of the real highlight moments for me was yesterday when I visited Mayor London Breed in her office in City Hall, and she gave me the opportunity to go with her to the rotunda and pay personally my respects to Senator Feinstein. So I really feel very good about that. Okay, so let's move on and talk about COVID. As you well know, a brand new virus, a novel coronavirus identified, associated with some unexplained pneumonias in the end of December of 2019, identified as a novel coronavirus in the first week in January of 2020. For those of you not familiar, coronaviruses are not new viruses to us. Shown on this phylogenetic tree, the viruses in red font are the human coronaviruses, and those on the lower right and the upper left are the 4 common cold coronaviruses. So we've known about coronaviruses like forever. So it isn't a new virus, but what happened, as we well know, in 2002, we had the first SARS coronavirus, which was really a mini outbreak of about 8,000 cases and about 785 deaths. And then in 2012, we had MERS. And then in 2019, we had the evolution of this brand new coronavirus, which, as we all know, has been of historic proportions. So let's just talk about it and the impact on us. The first cases from the central region of China in the city of Wuhan. In the United States, the first travel-related cases, just to refresh your memory, because the interesting thing about a pandemic of a transformative potential is that when you're living through history, you don't know you're living through history until you look back and say, oh my God, what has just happened to us? So we're 3 years, 9 months into the outbreak, but the first travel-related case was in January 20th, reported by the CDC on January 21 of 2020. Fast forward a couple of months, the WHO finally declared it a pandemic, even though those of us were talking about it being a pandemic quite a bit before that, when we reached about 120,000 cases in over 100 countries, and we had about 5,000 deaths. So now let's really fast forward to a couple of days ago, in October the 2nd, the reported cases were about 770 million. That's an amazing undercount. We know that for a variety of reasons, that many of these cases are not reported. The reported deaths are about 7 million globally. You know, there's estimates in modeling. Is that a 2-fold or a 3-fold undercount? Most people say it's somewhere around 20 million deaths globally. If you look at the situation that, by the way, in our own country, the undercount of cases is profound. I mean, supposedly 100 million cases, but I have to ask this sophisticated audience a question. How many of you who've been infected did a home test and did not report it to anybody? Okay. So then you know the undercount of it. But the thing that's not an undercount is the 1.14 million deaths that we've had in this country, which, as a developed, rich country, is right up there in the top 2 or 3 in a per capita number of deaths. Okay, so where are we now? WHO on May 5th declared it that it's no longer a global health emergency, and the CDC called off the public health emergency declaration on May 11th of 2023. So the question that people ask is, are we over with COVID? Well, we're going to get into that in the lessons learned. But this is an interesting, and I'm going to get into this in one of the real unusual aspects about COVID. If you look at hospital admissions in the United States, going right back from when we had Alpha. Remember, we had the original Wuhan ancestral strain for a couple of months. Then we had Alpha, and then we had Beta, then we had Delta, and then in Thanksgiving, I remember because it was, as I was sitting down for my Thanksgiving meal, I got a call from South Africa saying, by the way, we have a really strange new virus, which turned out to be Omicron. And we'll talk a little bit about Omicron in a bit. And I was asked, where are we now? Well, you know, it's very interesting because if you look at the hospitalizations and look at deaths, up, 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 and then it goes way, way down. And then it starts to come back up again. About a month and a half ago, we were having an increase in cases, but the CDC announced last week that the previous 2 weeks has actually plateaued and started coming down. But given the roller coaster effect that we've experienced over 3 years and 9 months, I mean, I think it's naive to think it's going to keep going down as we go into the winter. I would imagine it's probably going to continue to go up. So that's where we are right now. Again, if you do monitoring, wastewater monitoring, shows in the upper right-hand part, they're going down and now sort of plateauing. And it appears that wastewater monitoring is a pretty good indication of where we are, in that we no longer test a lot right now. So that's the background. So when you get to the point, and the reason when you want to compare, again, just to refresh your memory, I know this audience is very well aware of that. In the peak of what was going on, we had between 800,000 and 900,000 infections per day, and between 3,000 and 4,000 deaths per day in the United States. Right now, the level is around less than 100 per day. So it really, really is low. So when you see a certain percentage increase, it's a percent on a low number, but it isn't over. And we're going to get to that in a moment. So when you get to that low point, you can drop back a few yards and say, what are some of the lessons that we've learned now retrospectively? There are about 100 lessons. I picked out 10 that I think are worthwhile at least discussing for a few minutes. Okay, so the 10 lessons from COVID-19. Lesson number one, as with all emerging infections, but even more so, expect the unexpected, because there are many aspects of SARS-CoV-2, the virology, transmission, pathogenesis, epidemiology, that have really shown to be an unexpected issues. First of all, we're dealing with a highly mutable virus that evades immunity and therapies. So if you look at the 3-year, 9 months as a season, because we think of emerging outbreaks that occur in a season, the influenza pandemic of 2009, the influenza pandemic of 1957, 1968, it goes way up in the winter, it comes back down, it peters off, and then it stays at a low level. If the season of COVID is the 3 years, 9 months, we have never ever seen a virus that had so many variants that have emerged within the same season. So let's think of the season as 3 years and 9 months. And if you look at this, you'll all know now, this is the phylogenetic tree of SARS-CoV-2, where I think, I'm afraid to press something because every time I do, I shut it off. Anyway, I'm going to go over there. Don't worry about it. We're good. So, I mean, obviously, when you look at the first ancestral strain, and then you had all the different variants, alpha, beta, delta, remember, we thought we were going to be free of COVID in the 4th of July of 2021, and then delta came and threw us for a loop. And then in the Thanksgiving of 2021, we had Omicron. And what we've had since then is all subdivisions of Omicron. I mean, Omicron was the original BA1, and then everything that we've had is a subdivision or a sub lineage of Omicron, which in the bad news is that it lingers. The good news is that it isn't yet another way out. Here's where we got hit for a loop, because from the standpoint of the ability to respond, that's something that, you know, we really were way out of touch with that. Now, also, BA 0.2.86, everybody got excited because that looked a lot different. That had about 35 mutations in the spike protein. As it turned out, it's a bit of a wimpy virus in the sense that it isn't very fit, number one. And number two, for reasons though, even though it's, you know, phylogenetically out there, the antibodies that we have against the other Omicron seem to cross-react pretty well. Now, what has happened is that over the years, 3.5, 3 years, we've had successive variants that have a number of characteristics. They seem to have increased growth capacity and elude the antibodies that were made either from prior infection or from vaccination. That was counterbalanced by the fact that it appeared to be not as pathogenic. So as the number of infections went up, the ratio of infections to hospitalizations went down. Now, there are a lot of reasons for that. Either something is inherently less pathogenic, or most of the population by that time had either gotten infected and or been vaccinated. So there was a degree of underlying immunity, which we didn't understand in the beginning, where people say, well, you say that prior infection and vaccines protect you. Well, it protects you against infection for literally a month or two. And then after that, you lose protection against infection, but you maintain protection against severe disease. So you have this confusing issue where people are getting infected, but the ratio of people who get hospitalized is much, much less than it was. So you can imagine, for those who want to throw bombs at the public health people, how they tell you, how you're telling us that vaccines work, and they don't really work. Well, they do. So one of the problems is that we can't be chasing every variant with a new vaccine. And that's the reason why the cluster of variants of Omicron is somewhat of a good news, because there's a lot of cross-reactivity. And the reason is otherwise we'd be playing whack-a-mole, because if we had a new vaccine, even with the adaptability of the mRNA platform, which is easily adaptable, much, much better than whole virus or whole killed or attenuated, it would be folly to try and chase it. And we'll get back to the booster situation, I'm sure, in the questions about the booster that's available right now. We always have to keep in the back of our mind something, and I'll give another cartoon here, that even though the variants seem to be covered by prior infection and vaccination, every once in a while we better be careful, is that just when we think it's over, a variant that is way out of the protection of the cross-reactivity. You know, honestly, I don't know, is anybody televising this? I don't think that's going to happen, but it could. So always expect the unexpected, and that's the reason why I have that as my first lesson. The other thing that really threw us, and it confused us about masking, when you look at respiratory illnesses like influenza, the approach to influenza is what's called a syndromic approach. Most of the transmissibility is from someone who is symptomatic, coughing, sneezing, not feeling very well. And that was the reason why the CDC early on felt that you really didn't need a mask, because, you know, just if you're sick, stay home, you know, cover your cough. Then we found out something very, very interesting, that 50 to 60% of all the transmissions are from someone who has no symptoms, either is in the pre-symptomatic phase or will never, ever get symptoms. Now, that threw all of us for a big loop, because remember that the reports of outbreaks among choirs or outbreaks at weddings where no one seemed to be sick. And then all of a sudden, 20, 30, 40 people at that particular event got infected. That is very unique. With influenza, maybe a couple of % of the transmissions are from asymptomatic people. Not zero, a few %, but not 50 to 60%. So that's important. Next, the arguments that we had early on about whether aerosol transmission actually plays an important role. You know, there's a lot of discussion about what aerosol means. You know, aerosol, you know, the 0.5 microns goes to the bottom and you stay 6 feet away. With all due respect, that's meaningless. If you have an aerosol transmission, it stays in the air for a while. And that's the reason why people who were in a restaurant over there, sitting there, and someone who was in a table over there got infected, because it had to be circulating in the air. We didn't know that until months into it. Remember, the WHO was insisting, and they're good people, that aerosol transmission does not occur. It does occur with SARS-CoV-2. Okay, lesson 2. The thing that we learned with all pandemics, but it became eminently clear with COVID, that when you have an outbreak of a highly transmissible pathogen, the increase is never linear. It's just not linear. We've got to learn that. It toots along like this, and then it becomes exponential. Because remember when the first cases in the United States came from Washington and the Seattle area, then we had New York. We thought, well, maybe you can control it. When you're dealing with a transmissible virus like this, what you see now is what happened 2 weeks ago. And what's going on now is going to express itself 2 weeks from now. And that's exactly what happened with us. So we need to act early and rapidly in a public health intervention. You know, there's this goal, and it's aspirational, of a 100-day mission goal, which means, and this was proposed by the G7 a couple of years ago, namely within the first 100 days from a pandemic threat being identified, interventions should be available that are safe, effective, and affordable. Diagnostics, therapeutics, and vaccines. That doesn't mean no way logistically this is going to happen, that you're going to get vaccines into the arms of everybody in 100 days, but you should at least have them made and ready to go. And I'll get into that in a moment when we talk about the science. Lesson 3, global information sharing and collaborations are essential. We knew early on in the pandemic, we were getting information from China that in typical fashion, very similar to SARS-CoV-1, if you want to call it that there was the initial, well, it isn't spread very easily from person to person. It's likely, you know, from an animal to a human, but kind of like bird flu where you don't transmit. Then you find out a week or 2 or 3 later, well, it's transmitted pretty well from person to person. And then 3 weeks to a month later, it's really, really transmitted well. And then you find out from satellites over China that they're building 1,000-bed hospitals overnight. So something really was wrong. That was not called good collaboration and information sharing. I must tip my hat, actually, to our South African colleagues, our Israeli colleagues, our UK colleagues, who in real time were talking to us about what's going on there and really get information, like the heads up from South Africa about Omicron when they first saw it there. So good information sharing and collaboration are essential. Lesson 4, leverage and build on existing infrastructure that you have. When you're preparing for a pandemic, you can't start from square one. Otherwise, you've lost the game. And luckily, and this had a lot to do with some of the colleagues here from San Francisco, early on in HIV, in the mid-1980s, I began to build what turns out to be the largest clinical trial network domestically and internationally for any disease ever, for HIV. So what we did is that we needed to get a clinical trial network to test the vaccine like overnight. It would have taken 5 years to build it. So what we did is we took the HIV Vaccine Trials Network, the HIV Prevention Trials Network, the ACTG, and we leveraged them to now become the COVID-19 Prevention Network, or COVE-PN. And this is the map of the world showing all of the sites that had previously been used, some right here in San Francisco, for the treatment, prevention, care, and vaccine for HIV were completely leveraged for the vaccine trials that we'll get to in a moment. Lesson 5, and I want to spend a few minutes on lessons 5 because, you know, that's what many of us are all about. The story behind vaccines. I wrote in an article in Science in April of 2021 that the speed and efficiency with which these efficacious vaccines were developed and the potential for saving millions of lives, what they didn't happen overnight. It was due to an extraordinary multidisciplinary effort involving basic, preclinical, and clinical science that was underway under the radar screen literally for decades. And let me march through that with you because it's really important when we argue to the Congress of the support of basic and biomedical research. So let me talk to you about that. You can think of vaccines, and I know you're aware of this, but let me just say it just for clarity, that there's a vaccine platform and there's a vaccine immunogen. The platform is how you're getting the vaccine in, killed, live attenuated, recombinant DNA, messenger RNA, viral particles, etc. The immunogen is what actually the disease antigen is. Is it polio, measles, mumps, hepatitis, SARS? So let's take a first look at the vaccine platform, mRNA technology. The mRNA technology was not an overnight phenomenon, as I'll mention in a moment. If you look at the original observation that allowed us to use mRNA as a vaccine, it dates back to a paper from Katie Carrico and Drew Weissman from 2005 in the journal Immunity, in which they modified the RNA molecule so that it didn't trigger an inflammatory response that would negate its use as a vaccine. So it could be now used as a vaccine. It took them years to get to that. It was worth it, as we'll see in a moment. The next thing is an immunogen. And here's where the interdigitation of fundamental basic research on HIV actually led to the optimal immunogen for COVID. And I'll explain. Now, several years ago, more than 20 years ago, we put together the NIAID Vaccine Research Center for the purpose of making a vaccine for HIV. And it was an interesting, when I hired this group, I hired people, all of whom were not NIH people, except for one person, Bob Cedar, who happened to be there. Everybody else came from different parts of the country. Two of them, Peter Kwong, who's a structural biologist for HIV, and Barney Graham, the tall guy with sunglasses and the red circle around him, who had a peripheral interest in HIV, who was really interested in respiratory syncytial virus. So that was his passion throughout his life. Okay, so what happened when Peter Kwong was working on using cryo-EM to get the right structural conformation of the HIV envelope, he was literally across the hall from Barney Graham, who had little interest in HIV, was worried about RSV. So they met, and what Barney learned from Peter was that if you structurally stabilize a molecule, and this is the RSVF protein, in its pre-fusion form, which was very immunogenic. So when you look at an antigen, the pre-fusion form is much more immunogenic. The post-fusion form is not as immunogenic, except this is stable and this is unstable. So how do you stabilize the molecule to use it as an immunogen for a vaccine? You make some mutations that are stabilizing mutations. Barney did that for RSV. That's the good news. The better news is that we now have RSV vaccines based on Barney's stabilization of the immunogen. But then along came the coronaviruses, and Barney said, maybe I can stabilize the spike protein of MERS, remember MERS from 2012, and find out if we can get a very, very stable, highly immunogenic spike protein. He used the same mutations that took him years to develop for RSV and applied it to MERS. But you know, MERS is not a problem for us. It was sort of like a form thrust of an outbreak. We still see it in the Middle East. So when SARS came along, Barney told me in our conference room, get me the sequence, which we got on January 10th, and I will make the spike of that stable with the same mutations, the S2P mutations, to stabilize it. So as soon as the sequence came out, Barney immediately did that. And these are the list of the vaccines. And you look at the right-hand part of the slide, every single one of those vaccines actually are using the S2P mutations. Not only the Moderna and the Pfizer, but every one except for one of the vaccines. Now, if you look at what that allowed us to do, it has been completely unprecedented in the history of vaccinology. So go from the left part of the slide to the right part of the slide. Barney told me, get me the sequence and I'll start on the vaccine. 5 days after that, he was partnering with Moderna. They started it. 65 days later, we were doing a phase 1 trial. 139 days later, we were doing a phase 2 trial. 198 days a phase 3 trial. And 11 months later, with the clinical trials using those networks that I showed you on the map, we did we did 4 or 5 clinical trials of 10 to 30,000 people per trial, and showed in November and early December that the Moderna and the Pfizer were 94 and 95% effective and safe. Less than a year getting vaccines. That is beyond unprecedented. And let me show you why. This is a little bit of a tongue-in-cheek slide. If you look at the time from the development of a vaccine to the time it was identified with typhoid, as you know, it was 105 years, polio 47 years, pertussis 42, all the way down to COVID, which is the fastest in the history of vaccinology. Now, that's not just a scientific accomplishment, it's a public health accomplishment, because you could estimate, the Commonwealth Fund estimated that between December 2020 and November 2022, more than 3 million lives were saved, 18 million hospitalizations, and over $1 trillion in medical costs from a vaccine that was developed in less than a year. Now, as you might imagine, that was pretty exciting in the scientific community. Science magazine deemed this in 2020 as the scientific breakthrough of the year, which it absolutely deserved. Time magazine appropriately picked out Drew Weissman, Katie Carrico, Kizzy Corbett, and Barney Graham for their combination of platform plus Immunogen to say they were the heroes of the year. And we all know now that just a few days ago, Katie and Drew were awarded the Nobel Prize for their work of the COVID vaccine. It was really very, very well deserved. I sort of smile when people say, Drew was a fellow in my lab for 5 years. We published about 20 papers together, and people say, well, you must have been involved, and it had nothing to do with it. It was him. You know, it's one of those examples that I know many of you know. When you have a brilliant fellow in your laboratory, the thing to do is to give them encouragement, support, point them in the right direction, and get out of their way. And that's exactly what I did with Drew, which was a good thing. Okay, lesson number 6. This is important for preparedness, that there are 2 approaches to get you well prepared for the next pandemic. One is the priority pathogen approach. So you pick out something that as an individual pathogen, you feel has pandemic potential. The WHO and CEPI have already done that. For example, Crimean Congo hemorrhagic fever, Nipah, and others are a good risk to be a pandemic someday. But an even better approach is something called the prototype pathogen approach, which we at NIAID had been promoting. And I'm going to tell you a little bit the story about that. What that means is that you build on prior experiences with viruses in the same family. So a few years ago, I wrote about this, but it's not my idea. The idea is totally Barney Graham's, who felt and came to me and said, you know, Tony, why don't we do this? Why don't we invest in there are about 100 viral families that can actually infect humans. About 25 of them have some pandemic potential, and about 7 or 8 of them are much more high risk for developing into a pandemic. Coronaviruses, flaviviruses, orthomyxoviruses. So why don't we invest the money to do the following? Take a prototype virus from each of those families and do basic virology, develop assays, animal models, antigenic targets, optimum platforms, immune correlates, and even get a phase 1 trial in each, so that if you do get a pandemic emerging, you'll go way, way ahead of the game. We actually did that inadvertently with the coronaviruses, because remember, we knew what they were. We worked with SARS-CoV-1. We worked with MERS. And as soon as the novel coronavirus came, we had all of our experience of multiple years. If we can do that with every single of those families, I think we'll be in good shape. Lesson 7, we have to increase attention to the animal-human interface. Emerging and re-emerging infections, essentially 75 to 80% of them are zoonotic. They jump from an animal to a human. Human health is absolutely connected to animal health. It's precedented. It's not new. There's nothing new here. HIV, chimp to human. Ebola, animal reservoir to human. Influenza, birds, ducks, chickens, pigs, humans. On and on. Not everyone, but the vast majority of one. So my colleague David Morans and I wrote in Cell about 3 years ago that, there's a very complex reason why this happened, but most of it is the unbalanced interactions between the animal world and nature, where you either encroach upon the animal kingdom by delving into rainforests or climate changes where ticks and others get closer to the humans, or you bring the animals into it, like we saw in the wet markets in Wuhan. So we don't know what the origin is. I mean, there's arguments about this, to the extreme. But if you look at what experienced virologists from all over the world, Canada, Australia, the UK, the European Union, the United States, strongly suggest, without definitive evidence, that there were, we know there were animals in the Wuhan market that should not have been there. They were outlawed, but they were there. And you wind up having an explosion of cases that are related to there. Again, we don't know exactly how the outbreak started. It could be any of a number of things, certainly including a lab leak, but the predominance of evidence strongly suggests, without definitive proof. And then there was a number of other studies that were done by very, very good virologists. But putting that aside, looking forward, what's the lesson we've learned? We've got to reduce the risk of pathogen spillover by doing a number of things. Better surveillance of the interface between animals and humans. And we could do that. There's an effort called One Health, which means the health of animals and humans are interspread. We got to stop clearing and degrading tropical and subtropical forests indiscriminately. You have to do a little bit of that, but it's being done in places like Brazil and other places indiscriminately. We've got to improve the health and economic security of communities that live in those areas. We've got to enhance biosecurity and animal husbandry. And for goodness sakes, we've got to shut down or strictly regulate wildlife markets. It's crazy to bring animals that are in contact with bats, to bring it into a market where people can go in like you're going into, a supermarket and wind up getting exposed. Lesson 8. This is a painful one because we've seen it with multiple diseases, including HIV, that long-standing systemic health and social inequities are the drivers of pandemic disparities. We've seen that with COVID. If you are an individual in a minority group or a lower socioeconomic group, and that's African Americans, Hispanics, and others, Native Americans, you have a greater chance of having an essential job that would put you out into the environment and not behind a computer like many of us were able to do, number one. And number two, you had underlying health conditions such as increased incidence of, you name it, diabetes, hypertension, obesity, chronic liver disease, chronic kidney disease, which if you do get infected, gives you a greater likelihood of having a serious outcome such as hospitalization and deaths. So what are we going to do about these long-standing disparities? Obviously, there's discrimination, which dates back, if you talk about the social determinants of health, I could give you a whole lecture on that, going back to racism that continues to permeate certain aspects of our society. Individuals have limited healthcare access and use. The occupations I mentioned, educational income and wealth gaps, and housing. you generally don't think of housing as a public health issue. But when you have multi-generational homes of people who are susceptible and those who are out doing essential jobs, that's how you get outbreaks of infection. Now, I have to tip my hat to San Francisco and Grant and his colleagues and others who actually really did something that is very, very admirable, is to address the health disparities and to do any of a number of things as a model. And I'm saying this not gratuitously because I'm here in San Francisco, but San Francisco always seems to be, in a positive way, pushing the envelope ahead of the game. From the wards you had in San Francisco General in the first couple of years of HIV to recognizing disparities within the context of COVID. And you guys have written about that, and it's a very, very good article. Lesson 9. Welcome to my world. Okay. Misinformation and disinformation really is the enemy of public health. And it's really sad how when you look at the misinformation and disinformation, it's like nothing that I have ever seen. I've been at the NIH for 54 years. I was the director of the Institute for almost 40 years. And I've seen some distortions of truth, but I've never seen an overwhelming distortion of reality, where we're living in an era where is the normalization of untruths. Years ago, if you said something that was egregiously wrong and it was proven to be wrong, you would be shamed and no one would listen to you again. Now, if you say something that's egregiously wrong and proven to be wrong, you get more votes. So unfortunately, that's where we are. So the real question is, how do you respond to that? And that's really now become a real problem, because I'm sure some of you in the room have been following this. The new weaponization, I call it the weaponization of the First Amendment, which means that if you say anything against an egregiously incorrect thing, like Tony Fauci and Bill Gates put a chip in the vaccine, you are actually encroaching upon someone's First Amendment right to freedom of speech. So you really can't do that. In fact, there was an interesting experience that I had, that I was telling people they needed to get vaccinated. They needed to realize that ivermectin and hydroxychloroquine do not work. And what happened to me? The state of Missouri and the state of Louisiana and the people from, you recognize some of those names like Bhattacharya and those, sued Joe Biden, Becerra, me, Vivek Murthy, for encroaching upon the First Amendment rights of people by saying that these things don't work. So I had to experience a 7-hour deposition from a very hostile lawyers. Now, a 7-hour disposition doesn't mean it takes place over 7 hours. It means you get disposed for 7 hours. So if you go to the bathroom for 15 minutes, that doesn't count, okay? So you have a 7-hour disposition. And of course, after the disposition on the social media, they said, absolutely, Fauci was encroaching upon the First Amendment rights. But then, luckily, these Superior Court of the Fifth, actually, what is it? It's the Fifth Court of Appeals came out with the following. And I got to show you this because I got so pissed off at that. I just got to show you that. So it says, for NIA officials, it's not apparent that they ever communicated with social media platforms. Instead, the records show that at most, the public statements by Director Fauci and other NIAID promoted the government's scientific and policy views and attempted to discredit opposing one, which are quintessential examples of government speech that does not run afoul of the First Amendment. Thank you, Fifth, okay. Anyway, sorry, I had to get that off my chest. It's sort of like, all right, lesson 10. My old hero of my boyhood, Yogi Berra, it ain't over till it's over. What do we mean by that? Where are we now with COVID? in 2023 and beyond. I explain it, and I think it's pretty simple to understand. When you're dealing with a pandemic, you've got to ask yourself a couple of questions. Can we eradicate COVID? And the answer I can tell you with some confidence is no. And the reason is we've only eradicated one infection in the history of public health, and that's smallpox. And why were we able to do that? For several reasons. Smallpox, as deadly as it is phenotypically stable. The smallpox that killed the pharaohs is the same smallpox that we eradicated in 1980, number one. Number two, there was a widely acceptable global vaccination campaign. Number three, most importantly, the immunity that you get from infection or vaccination is measured in its duration minimally for decades and maximally for a lifetime. So that's how you do it. Number two, can we eliminate it? In this country, we've eliminated polio and we've eliminated measles. How were we able to do that? Take a look at them. Number one, there's no animal reservoir, but that's okay. Number two, measles is a phenotypically stable virus. I'm old enough to have gotten infected with measles because I was born before the measles vaccine. Once you get infected with measles or vaccinated with measles, the duration of your immunity is measured minimally in decades, maximally for a lifetime. In addition, there's a widely acceptable thing. That's the reason why we've eliminated. What about SARS-CoV-2? It has none of those characteristics. I've just shown you several slides that said that it is phenotypically very diverse, and we've already had multiple variants. So the idea that you're going to eliminate a virus that continues to change, there's lack, I don't need to tell you that, of a widely acceptable acceptance of safe and effective vaccines. And we know, unfortunately, that even when you get infected or vaccinated, the durability of protection, woe is us, is measured in months to a year and not decades to a lifetime, which is the reason why you have to get boosted as much as you don't want to do that. That's the reason why you really need to do that. So what are you left with? Control. What do we mean by control? On the right-hand part of the slide, for some that means return to normalcy, where the virus doesn't disrupt our normal daily interactions. We're pretty much there right now. I mean, people are essentially going about much more than they did a year and a half ago. Some refer to it as endemicity. Some refer to it as the equivalence of other acceptable respiratory infections. The only way we're going to do that is by some really common sense public health measures. Number one, continue to boost to keep your immunity up. Number two, common sense things like personal hygiene, particularly if you are at a risk, an individual, the elderly, underlying conditions, living with someone with underlying conditions, wear a mask, have good ventilation, as well as doing a number of other things like good antivirals. We have a couple of good ones, but we don't have great antivirals. I mean, better than influenza, but not still great. So what about beyond COVID-19? The last paper that I wrote as director of NIAID was published, I stepped down in December 31st of 2022. So this was my last official NIAID paper in the New England Journal of Medicine, where I went back to my boyhood hero, Yogi, and I said, it ain't over till it's over, but it's never over. And let me explain, I don't want to get you depressed, but let me explain. When you talk about pandemics have been with us before recorded history. I mean, if you look, we're going way back, the plague of Athens, we had no idea what that was. The Black Death, we know now that's Yersinia pestis. Nobody knew in the 1300s that killed 1/3 of the European population. So the idea that there are emerging infections that can wipe out populations has always been with us. Now, the first time I testified before the Congress of the United States for the budget, and since then I've done that, quite frankly, more than a couple of hundred times, about 275 times. I drew a map and I stuck in the middle and I said, this is an emerging infection. I said, and we had to be careful that there will be other emerging infections. I didn't draw the map. I'm not that good an artist, but one of our graphics people drew this for me and put that HIV. So ever since then, I've testified because of Congress multiple times each year for close to 40 years. There's always 1 or 2 or 3 new infections that are either emerging or re-emerging. The last time I showed this was, I think, in the fall of 2022. This is what the map looked like. Now, many of these are just curiosities and trivial and don't cause pandemics. However, if you look at the time from 1981 to the 2023, and the dark part is the time when I became director in 1984, just in my own tenure, if you look at the diseases that have emerged that we've identified, it's been extraordinary. I mean, emerging and re-emerging diseases are actually here to stay. We've had them before history. We've experienced them now. It is completely naive to think we're not going to see them in the future, which is the last slide, which is a paper that my colleagues and I wrote several years ago, which is as true today as it was then. That emerging and re-emerging infections, as I hope I've convinced you of, is a perpetual challenge. The only way you meet a perpetual challenge is by perpetual preparedness. And that is the final lesson of COVID. We absolutely must keep the corporate memory of what we've been through, so that when we get this behind us, we don't look at the next problem that's facing us, but we remember that we have to be prepared for the next outbreak. Thank you. 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 Thank you.
We had a little time for questions.
Sure, sure. Of course. Of course. Go ahead. Yeah.
Outstanding.
Thank you.
Wonderful. Thank you for all you've done. You stay so strong in the face of so much adversity, because people were so throwing so many darts at you, so many weapons, trying to do all kinds of terrible things to you, but you've been strong and resolute. I think it's because you're from Brooklyn. New York, but just can you just share what it's like to just maintain the strength of character that you have over these 40 years, but particularly in the last 3 years where you've been personally attacked so terribly by so many.
Yeah. Well, thank you. Thank you for that. It's a complicated issue, but what I think it relates to, and I made this decision a long time ago, even during HIV, when there weren't really a lot of attacks, but we were doing intensive type of involvement in what we're doing. If you focus like a laser beam on what your mission and what your goal is, and for me, and I describe this to people when they ask, many people in the room are physicians who take care of individual patients. So, I mean, I'm a classically overtrained physician, 4 years of residency, chief residency, 3 years of a fellowship, and I've taken care of thousands of patients. And when you're dealing with an individual patient, you focus like a laser beam, and everything you do has to be directed to the preservation and the promotion of the health and the safety of that individual patient. When you take the responsibility as a public health person, like I essentially fell into in my position, the entire country becomes your patient. And you have to do everything you can to preserve and protect the health of that patient, which happens to be the country. If you focus like a laser on that, all the other stuff is noise. It's not pleasant. I mean, nobody likes to have elected congressmen and senators aiming at you every single day to try and discredit you. But if you focus on that, you're going to drive yourself crazy. And I just try my very best not to focus on that. Also, to be honest with you, I have a good support structure. I have an amazing wife who's the greatest shrink in the world, and I don't have to pay her. Yeah.
Thank you very much. And also, I want to I want to thank Dr. Fauci for taking time during his pandemic to prepare a video for the UCSF School of Medicine graduation ceremony. It was really, really wonderful and helped us at a very difficult time. I'm wondering if you could talk about any thoughts you have about a public health response to the misinformation, disinformation issues that you talked about. Is there an intervention that can follow the same sort of control, elimination, eradication pathway? And it feels like another part of pandemic preparedness, because once misinformation catches hold, it's hard to get rid of it.
Yeah. You know, I'm sorry to say that I don't have an easy answer to you. I thought that by essentially screening out egregious misinformation would be the answer. But the courts have argued against that you can't do that. You were able to pull out of social media things that were clearly, if not deliberately directed, had the result of people not utilizing interventions like vaccines, leading to the deaths of individuals. And the courts say you can't do that. So to be honest with you, I don't know. Oops, that happened. And usually somebody leaning against the wall. I don't know how to do that. Vivek Murthy, our Surgeon General, really a phenomenal guy, is making that actually his thing. That and the mental health of the young population with social media and how it distorts people. But I got to tell you, I'm struggling. Peter Hotez, one of our colleagues, wrote a book recently about the deadly effect of anti-science. And he estimated that if you model the number of people that have died because of misinformation telling them not to get vaccinated is 200,000 people over the last 3 years and 9 months. So 200,000 people have died because of misinformation. And it is such a tragedy that, you know, if you look at red states versus blue states, the amount of vaccination adherence in red states is very low, and the amount in blue states is high. And it seems astounding that if you are a Republican, you have a greater chance of dying from COVID than if you're a Democrat. How crazy is that? That somebody's political ideology. I mean, I'm not a political person. I'm not a Democrat. I'm not a Republican. I've never been involved in politics at all. But to see people who, for only reasons of their ideology, are not getting vaccinated is completely nuts. I'm sorry, I don't have a good answer for you. Yeah, yes.
Well, segueing from that, on behalf of my home state of Missouri, I would like to deeply apologize to you and to everyone in our profession for the idiocy of my state. There are, I think, factors of sanity and science still there. So I think my question is really in the same way that we think about having a stable of kind of shovel-ready vaccines to go, and as we also think about like the court system and how we, grow the court system, how can we support the public health infrastructure of some of these states that really struggle politically, and support people who still want to go into the field? And so many people who were, in this world resigned and feared for their lives and everything like that. So how can we prepare in that way as well?
It's, I think, just what you're alluding to is greater support for the public health infrastructure. If you look at even though technology has advanced greatly over the last couple of decades, if you look at the public health infrastructure in this country at the local level, the public health departments, before we had highly effective vaccines and antibiotics and antivirals for everything, that was really the core strength of the country, was the local public health. As a victim of their own success, they pulled out resources, and people, the good young people who wanted to get involved, didn't get involved at that level. We have to recreate the local public health infrastructure. And that's what I hope the CDC is going to do in their rethinking about how they're going to restructure themselves, because the money that they get, they've got to really have a firm partnership with the local public health at the state level. Because right now, as crazy as it seems, there is a disconnect between the federal CDC and the local, is that the states don't have to report they only do it willingly to the CDC. So you wind up with states that have political ideologies. I mean, look at Florida. I mean, come on. That's a problem. Yeah.
Adding my thanks to everyone here. We're all so grateful. But adding on the questions about the disinformation, I just wanted to get your thoughts about communication more generally, which is something that we and many people struggled with. When the information that you're trying to communicate is constantly changing, I'm just curious what lessons, maybe it was somewhere in your top 100, but what did you learn about? But curious about lessons learned regarding communication when the information's changing all the time.
Yeah, it dates beyond our control now, and it has to do with science literacy, that we really need to essentially put a lot of efforts into that in children who are in school. To not necessarily everybody should be a scientist, but what we don't do in this country, which other countries do, is to get an appreciation of what the discipline of science is and what the difference between different subgroups of science, like the physical and mathematical sciences versus the biological and health sciences. We've learned for absolutely certain that, and I showed you with the slide, how the virus changed over time. So what we knew in January is very different from what we knew a year later. And what the public sees is they see scientists continuing to change their mind, not appreciating that when you're dealing with the biological sciences, science is a self-correcting process. We know that. I mean, again, how many of us, when we were in medical school or in our PhD programs, in our internships and residency, the things we did then that now just don't work anymore, and you've got to do something a bit different. Does that mean that scientists don't know what they're talking about? No, it means that as you learn more, you modify your look. And the example I use, and I think it's a pretty simple example, and you try to explain that to the general public. Well, you said this in January of 2020, and now it's 2021 and 2022, and you're saying something different. My answer to them is, in January of 2020, 2 + 2 = 4. In October of 2023, 2 + 2 still equals 4. That's math. But the virus in January 2020 and what we knew about the virus in 2020 is very different from what we know about it now. And you've got to realize that science self-corrects, and you make statements and guidelines and the kinds of recommendations based on your best knowledge at the time. That's something that is difficult for the general public to understand. We've just got to keep trying to educate them about that.
Thank you. Thank you so much for your presentation. Isela Ford here with the Health Department. I just wanted to reflect a little bit on the slide that you shared around our ability to expand our knowledge and experience that we had during the HIV epidemic, and really using those lessons learned for our success here in San Francisco. We partnered very closely with community, and I think what added to our success was our ability to share this information, really bring it down to a low barrier, community-centered information sharing practice. So I'm wondering, as we look to the future and this perpetual preparedness and being better prepared, bringing our community partners along, do you see a way for us to operationalize some of your lessons learned and your presentation here, really bringing that out and bringing it closer to the folks who supported the work on the ground? Thank you.
Yeah, the answer is yes. And I think, again, not to be gratuitously saying this to you, but San Francisco does a great job of that, taking the conceptual issue of the relationship of the community to actually what's going on and the kinds of policies you make. Everybody says all politics is local. Well, all public health is local. And that's the reason why you've got to learn. And we learned, from the activists here in San Francisco and in New York during the early years of HIV. what we learned and the policy changes we made by listening to what they had to say and realize that although, like us, we weren't 100% correct, they weren't 100% correct, but we learned an incredible amount from them about how to, do clinical trials, about how to involve the community in clinical trials, about how the regulatory elements in the FDA were not well matched to what we needed. So we absolutely have got to continue to use those lessons. Hi.
Dr. Fauci, thank you so very much. I wanted to ask you to comment on NIH's role as a research funder of communication research, behavioral research, all of the research that perhaps would have helped us do a better job, perhaps not, but perhaps would be helping us to do a better job, not only in combating misinformation, but in helping different individuals and different communities have better understanding of what we're talking about. Dr. Collins was quoted as saying that perhaps NIH should be doing more in this space. And I wonder what your thoughts are about that.
It sounds like I planted that question for you. Well, I agree completely with Francis about that, but I don't know whether you're aware that you are aware, that's the planted question, is that the NIH felt very strongly that given the potential deleterious effects on public health of misinformation and poor communication, that they had a $150 million to $200 million grant that, not grant structure, not one grant, to give out to the community to put in proposals to address your question. And because of the pressure from the far right in the Congress, the extreme right, which is essentially making our government dysfunctional, the NIH pulled back on the grant. I wish I were back there, I wouldn't have let that happen, but they pulled back so that people were getting excited about submitting proposals. Were you one of them? Sorry. And that would have really been money very well spent. But because of the extreme pressure that was put on the NIH by the extreme right elements in the Congress, they decided it wasn't worth the harassment and they pulled back, which is unfortunate. That's, I can empathize with them in some respects for doing that, because they didn't want a whole bunch of other crap to fall on them if they did it. But it's a shame that they gave in to that, because we really did need that. Yeah.
Hi, Dr. Fauci. So I want to say thank you for your, at times, intense press conferences that you did daily. I don't know if you've ever been called this, but at a critical time, you are America's doctor. And what we try to do in San Francisco is, obviously, we try our best to serve the people in San Francisco, but we also try to be an example to other communities. And I just want to hear not only what kept you sane, sounds like your wife, but then also, how do you approach the role of having to understand that what you're saying and what you're giving to the world is not just for this moment and these people in the room, but it's going to be in history books? Like, how do you carry that weight as an individual, as a doctor, and as a humanitarian?
Well, thank you for that question. I partially answered it to the question of the individual a little bit earlier. So when you're dealing with health, again, I think it's a special obligation that we have when you're dealing with health and the life and the welfare of an individual person. You're not dealing with whether you're going to lose a little money on this project or you're going to do something, but something that is inherent to your existence, which is your health. You absolutely have to be entirely truthful, entirely transparent, and not get pressured into doing or saying things because you're getting pressure to do or say something. And that, gets to the situation I was in the White House during the Trump administration, where I just felt when we're getting to the point where clear distortions of reality, if people want to do that, who cares? I mean, I'm not going to try and, be the policeman of the world, but when somebody is saying something that I know is going to have a detrimental effect on the health of which I'm partially responsible for as a health official and as a physician, you have to speak up no matter what the consequences are. And that's what happened in those months. Everything was good in January, February, and then when we got to March and the end of March and the beginning of April, when the White House was saying, and Trump particularly, that it's going to go away tomorrow, it's going to be like magic, or this drug works or that drug works. As much as I had a great deal of respect for the presidency of the United States, I had to publicly disagree. And that set off a chain of events, which has, led to a changing of my whole life, unfortunately for me. But, that's what you have to do. It depends on, you almost assume a responsibility. You take the Hippocratic Oath when you become a physician. And even if you're not a physician, the physicians on their own ones, if you're in science, science is the mechanism to get to truth. And when you start distorting truth, then you're giving up and abdicating your role as a scientist. So if you really want to be a scientist or physician, you just got to go with it no matter what the consequences are. What history is going to judge that, who knows? But that's what you have to do. That's the way I looked at it. Yeah.
Hi, Dr. Fauci. Again, thank you for coming to speak with us in San Francisco. I wanted to ask you a question a little bit about on the softer side of science and healthcare. And the way I wanted to open this was one of my most enduring images of you was actually not during the pandemic, but actually during the first Ebola outbreak, where there was a patient who had gotten infected in Texas. And then one of the nurses taking care of that patient also got infected. And she fortunately recovered. And my image is actually of you giving her a hug. And I bring this up because the pandemic, for those of us in healthcare and science, has really kind of gutted us. Right. Record levels of burnout. And if we're talking about getting prepared for the next one, I think that we need to figure out a way for the system to be able to help us guard our hearts. Right. There was a lot of heroism that was called upon in order for us to get through to this point. But heroism isn't a sustainable healthcare strategy. Right. And as much as we all would love to have a hug from you, what kind of lessons did the pandemic teach us about maybe what was missing or what we can advocate for so that the job that we're doing to protect the health of the public, so that we can continue to do that and do that well?
Yeah, well, that's a great question. And with all the negative aspects and the suffering that we've gone through with COVID, and when I mean the healthcare providers, I think one of the positive things that come out of that is the realization for the incredible stress that something like an outbreak puts on healthcare providers, all healthcare providers, doctors, nurses, physical therapists, everybody that's involved in the care of the patient. I don't think that people appreciated until COVID how stressful it is to be in a situation that we all were in, where you're working, 18, 20 hours a day, and you have to come into work because there's nobody else to do the job. And you're making decisions that are very painful decisions about, you're almost triaging people. I hope that there's a realization now that we have to pay attention to the health of our health providers, which we never thought of that before. I mean, that wasn't even on the radar screen. And I think that that's one of the positive things that people really realize that now. The reason I hugged Nina Pham, and I did it very, very publicly, was because there was an incredible amount of discrimination, not only against people who were recovering from Ebola, but the healthcare providers that were taking care of the people who had Ebola. I mean, in Bethesda, Maryland, an enlightened part of our country, that me and my staff, who were every day taking care of patients, we were having people who didn't want their children to play with our children. Like, what are you talking about? That's actually the mentality of something. So we really got to make sure we pay attention to those things. Those are not intuitively obvious to people. Right?
Our schedule is coming up to the end of Q&A. Do you want to take one more question?
Sure.
Thank you, Dr. Fauci, for being here. I'm also thankful that I have this opportunity to be here. My question to you is, do you have any recommendations drawing from your years of experience in the public health field as a way to help reduce the health disparities in terms of, for us, be perpetually prepared, like for pandemic purposes?
Right.
Yeah.
So reduce health disparities is your question. Well, the answer is I do, but it's going to take decades, because people think health disparities are things that overnight came and overnight you're going to fix. And it's one of the few things, or maybe one of the more than a few things, that are going to take a decades-long commitment. Because if you look at some of the health disparities, like when African Americans and Hispanics and Native Americans had a greater likelihood of having severe disease if they get infected, leading to hospitalization and death, it's because of what we refer to broadly as the social determinants of health, which means that right from the get-go, they have a higher degree of hypertension, diabetes, obesity, chronic lung, chronic kidney disease. And when you have that, that leads to the health disparities. That is not a racially determined thing. I mean, the hypertension or obesity or growing up with a lack of an adequate diet to lead to so many other things. So we have to make a commitment now that we've seen it to some extent with other diseases. We've seen it absolutely up front and center with COVID. And the country has to make a realization that that bases on that slide I showed, discrimination, which goes back to racism, which goes back 100 and some odd, hundreds of years in our own country. So if you have a problem that was decades, if not centuries in the making, you're going to have a decades-long commitment. And I'm not so sure when you look around our own country now, what's going on about the elements of racism that are still here. I'm not so optimistic that we're uniformly going to see a change of that. But in the situation where we can, we should try and address it. But it's not going to be an overnight thing. That's unfortunate.
Well, thank you so much, Dr. Fauci, for. And just to emphasize with your comments on San Francisco's, that everybody in this room and everybody listening on the live stream played a major part in our response to COVID-19, which is why I think your comments so resonated with everyone here. And thank you for helping us think about how to be prepared for the next challenge. Dr. Fauci has a tight schedule. He generously agreed to stay after the formal part of this. And by the way, I don't think we got CME credit, but maybe we'll try to do that retrospectively. But he will be here. We have a little reception with some refreshments set up to mingle with all of you. And I just would ask that since there's so many people here and since he has had quite a busy couple of days already in San Francisco, that you're judicious with your individual time with him. So thank you so much. We appreciate you.
Thank you.